welcome to this research group meeting. We took a hiatus over the summer. There were travels, there were other things. We will, just as a enticement for the next research group meeting, Prajwal is going to be presenting his travels to the sites over the last month or so. It'll be very exciting. I got a preview. It's been very, very productive, and really thank all the hosts from Mauritius, Nepal, India, and Pakistan for doing an amazing job in welcoming him and making him feel home. And so that's great. This is very important for all of you to understand. The protocol is a component of a larger parallel processing work stream. There are 4 work streams as we enter ICEHALL. And understanding that is going to be very, very important for us to become successful, because, we're not working full-time, we're working, all of us are volunteers. And so knowing efficiently what to do, what's your lane, and how you can help is going to help us achieve the mission. This is perhaps one of the most important slides that I'm going to be presenting. So there are 4 components to the work that needs to be done as we enter ICEHALL in that conversion phase, to have a first participant in, or first family in, I don't know however long it takes us to get there. So obviously today we're going to talk about the protocol itself, but as we're writing the protocol, and I had a long discussion with Peggy Sharpie, who's going to be joining us as our regulatory lead, IRB readiness is very important. Without IRB readiness, we won't be able to work in any of the sites, or certainly not be endorsed by MGH, and therefore we would not be able to have the vehicle of Harvard working with us. So as we're doing the protocol completion in parallel, we will be working on what do we need to do to be ready for IRB. Right, so that's the second component that is not visible, is under the waterline of the protocol completion. This third one is perhaps the biggest challenge, and it is the setting up the operational infrastructure. And that operational infrastructure will require thousands upon thousands of hours from all the sites, certainly from the Secretariat and under the leadership of Professor Varma, in making sure that the payment system is aligned, making sure that the IRB is going on, making sure that we have buy-in from the local communities where we are potentially going to be operating, making sure that the governments and the state or the organization are aware from an administrative and a political point of view that we are going to be running this huge trial that will have 80,000 participants at goal. So that operationalization will need a lot of hours and a lot of people, and we'll have to bring, as we get funding, all the professionals that will make that happen. Just to tell you, it is a huge enterprise. I run clinical trials, as you guys know, for a living. And we're talking, while this is not going to be an interventional trial, but the concept is the same. At capacity, think about it, from consultants to full-time employees to full-time volunteers, we're talking 200, 300 people involved. So that we're going to do it in a phased approach. Of course, we're not going to be able to activate all 4 countries because we don't have the bandwidth. We will start with Mauritius and then expand rapidly to Pakistan, India, and Nepal. That's very important to know, because that under the waterline is going to be as frenetic a work as the protocol itself. The protocol is the intellectual summit of what we are doing, but it all relies on these 3 feeding layers to make it happen. And most important of all, perhaps, no money, no mission, right? So I have not even begun to get back to the capital campaign task force. I will talk to Steve and Nirali, who are the co-chairs. We need to kick that up in gear. There are a lot of leads that we've had, some of them warm, some of them cold. We're going to put them together, and we will need to raise the funds. Prajwal and I had a talk this Friday. All the sites are extremely excited to be able to do ICEHALL, but to them, if we don't have the funding, there is no go. So, so understanding this is the most important thing, most important slide of all the slides I'm going to be presenting. The protocol that we're talking about today is the protocol, but under the protocol, IRB readiness, country alignment and operationalization, and funding and philanthropy are going to be what is going to make the protocol meaningful, or else it can be just another document that is useless. So our goal, ladies and gentlemen, here is to turn version 8 into a submission-ready, fundable, country activating version 9, or whatever version it will go. And very importantly, a credibility and fundability review. So as you are reviewing the protocol, think about it. What are the implications for operationalization? What are the implications that we can do for philanthropy and funding, right? So that is very important. And again, as I said, this is not a page-by-page review. It is the conceptual laying out of what we want to do. And I have labored through really for 17 years without knowing it to bring the protocol here. Now it is for the community to take it to version 9, right? So it's going to be a collective effort, and we can do that. We have done that in the past during our wonderful time when we rose in the pandemic and did an amazing work distributing information that was scientifically correct. And this is, perhaps that was the test for us 4 years ago. This is now the full-blown why we exist kind of thing. This one sentence is worth 17 years of work for all of you guys, for all of us here. I'm going to read it slowly, digest it, learn it, know it in your bones. ICEHALL asks whether a community-owned, community health officer-led, digitally enabled, culturally adapted learning health system can improve chronic non-communicable diseases care across diverse low and middle income countries' health ecosystems. That, if you're able to understand what all that means, then you have an amazing up on understanding the whole protocol, not only the protocol, the work streams, but what we are all about, right? So in the next 5 years or however long it takes us, this is what ICEHALL is going to do. And understanding this one sentence version of what it means, as full of comma as it is, because what we're doing is complicated. As I tell people, if it was not complicated, it would be available at the drive-thru at McDonald's. We are doing something that has not been done in the world in global health. We're going to be not only innovative, we're going to be revolutionary in the way that we're going to be putting implementation science, in the way that we're going to be bringing stakeholders together, not as a top-down measure, in the way that we're going to revolutionarily change health ecosystems where we operate. So know the sentence pretty well. There are 3 aspects to this mission that we have. Our core disease focus. And so Syed and I, Professor Shah and I, have been talking about his whole notion of the CKM syndrome for years now. And have resisted that because that denomination, because that CKM syndrome is a cardiovascular pile. While so far, in so far as people understand, they understand diabetes better than they understand heart attack, but diabetes is more common to be as a to be displayed um, as a marketing tool, if you will, of what we want to do. It's all the same thing, but how you are viewing the elephant and the blind monks looking at the big picture. But after a lot of thinking, I have revised in the way that we are going to be defining CNCD, because Professor Shah's idea is right on. So all of that, the CNCD, also understand the details of why it has taken us all this time to define it for us. So CNCD, chronic non-communicable diseases, are related and preventable conditions of type 2 diabetes, coronary artery and kidney diseases. Kidney diseases is new. Hypertension and stroke. The reason for bringing hypertension and stroke, because hypertension is the silent killer. We need to acknowledge that in our framework. And stroke, we need to bring the neurology component to it, because I'm a neurologist, and not only because of a neurologist, but because stroke is a huge unmet need that is part of CNCD. It is, in technical terms, you can you can argue, but this is where we're going to go with, right? And the core geographies, you guys know, Mauritius, Pakistan, India, Nepal. And then the core ambition is to generate a practical roadmap for health for all. And that is very, very important, guys, right? Why? Because while in ICEHALL, we're going to be focusing specifically on CNCD, make no mistake, when Dr. Gupta and her team are going to be designing the curriculum for the CHO, the research curriculum that we're going to be designing for ICEHALL would be focused mainly on CNCD. But make no mistake, when Professor Varma and team would be establishing Mauritius as the training ground for community health officers worldwide, that curriculum will be similar in the clinical care, would be similar to a family nurse practitioner. So health for all is a larger attribute that we want to achieve aspirationally. As I tell you, guys, some of you know, we have been in touch off and on with Rotary Club International, and we have once we get going, we have the goal to engage RCI to make CNCD and the 52035 vision its driving force, as it has driven polio eradication for the last 50 years. So just for those who are not aware, polio eradication started as a single project in Manila, Philippines. Because it was so successful in the poor sections of Manila, it went all over Southeast Asia, and then Rotary Club International adopted it. And after millions of hours of Rotary Club volunteers, we are here. Polio has almost been eradicated. So we want to do that for CNCD through the 52035 vision. That is the ultimate goal. That is the core ambition. And we're not going to waver from that. In the next 2 years, 3 years, 5 years, while we'll be focused on CNCD, our goal is to be able to reach every corner of this planet through the 52035 vision, through the community health officer, to be able to radically transform health for the world. So in the nitty-gritty of this ICEHALL, we are going to be focused on clinical outcomes, community empowerment, health economics, capacity building, and policy translation. So those are the working engines of ICEHALL. We're going to be looking at clinical outcomes. We're going to be measuring community empowerment. We're going to be looking at health economics. We're going to be looking at capacity building. That capacity building is very important, because this is not going to be a one-all study. ICEHALL and ICEHALL 2, ICEHALL 5, ICEHALL 15, or whatever it is going to become the engine that will revolutionize healthcare system. and that political and administrative capacity building into policy translation is all inbuilt in this protocol. You will not think about it this way, but we do think about it in the core team. And I want to invite you to think of the ICEHALL protocol as achieving that, right? Now, this, I'm going to fly for this. You guys, all of you know what the current realities are and what is ICEHALL response. So in the way that ICEHALL will work at this tip of the spear end, we will, through the community health officer, will be able to identify people with CNCD early on before they know it. There are like over 150 million people in the world who have hypertension and don't know it. Our work, wonderfully led by Prajwal and Dr. Varma in the sociology of type 2 diabetes, has identified one of the major insights has been, at least working in Mauritius, that many of the people don't know, were not aware that they had diabetes until they went into diabetic ketoacidosis and ended up in the hospital. That is not to happen under ICEHALL. So that's very important, the early detection. Empowering communities and participation of shared accountability, that is going to be our biggest challenge in the seed scale social development theory. So we have talked about that. Primary prevention and disciplined chronic care. Not on Tuesday we go to Dr. X, on Wednesday we get a WhatsApp note that lemon juice cures diabetes, and on Friday we forget it all and not take our medicine. That disciplining of chronic care through the CHO is going to be key on how ICEHALL is going to fundamentally change the way health outcomes are measured and health outcomes become. We want to empower these distressed communities as advocates, not just as passive recipients of care. So that is going to be important, and that's what the CHO is going to do. And so ultimately the question is, can the 5-20-35 philosophy become a rigorous, measurable operating system? We are not looking at ICEHALL as a one-off study, as an intervention study, or as a health economic study. We are looking at ICEHALL as the Mac OS of Macintosh computers and the MS-DOS of PCs. I mean that. And I want you to buy into this, because that's the ambition that we have. We don't have an ambition to run a $10 million study and then we're done. This is going to be a lifelong, or this movement that we're building. This is what it's all about, right? Now, the design as a glance. We have talked about this many instances over the last years. The community and clusters, and that cluster itself, I'm going to come to it. That cluster randomization is innovative. It has come about in the last 10 years in interventional studies, where you don't randomize single individual, but you randomize a community. In this case, we'll be randomizing families within the communities and hope that all the families will get together and form a randomized cluster. And then we will have the comparator, which is the standard of care. And then we have the ICEHALL intervention, follow-up assessments, and then outcome measures. So that's the study design as a glance. And if you read the protocol carefully, you can see that all over the place. Compared it, as I mentioned, with the standard of care. The primary question, this is something that you want to know. What is the primary outcome measure? The primary outcome measure is, does ICEHALL intervention, the whole shebang, from the community health officer to the community mental health to the digital and AI intervention, does that intervention in this context of ICEHALL improve CNCD care compared to community standard? That is the simple our hypothesis is that ICEHALL intervention will improve. And our goal is going to be disprove the hypothesis. And then if it's not disproved, then we are where we are. There's a whole host of secondary questions. It is overwhelming for someone who reads the protocol, and someone read the protocol this week and they were overwhelmed, and I sympathize with them. There's a whole host of secondary questions. These secondary questions are not going to be answered necessarily by every site. We may have several sub-studies depending on what resources we have. But in essence, the secondary outcome measures, the secondary questions the secondary questions are not going to be powered. We're just for our own insight and generate more data for policy implementation. Does the model change behavior? As you all know, behavioral change is the graveyard of chronic care, and it's the graveyard of global health. You can give people something, a sugar rush with an intervention, but that goes away. But with the constant feedback from the CHO, are we able to change behavior in a sustainable manner? Can we build trust in the communities we are reaching? Can we reach everyone fairly, not only one segment of the population? Can we lower cost? Can we strengthen capacity from Espérance Trébuchet to the district of Rivière-du-Rempart, to the north, to whole of Mauritius, and so on and so forth with each of the sites? And can we have the communities themselves become advocates to expanding the message of 520-35? All of those are the secondary questions and the interventions that will happen all along ICEHALL, right? The master protocol principle that we're working here is that we will have a master protocol that will have everything, and then we will have country-specific adaptations. Something in Mauritius may not work in Nepal, may not work in Visakhapatnam, or may not work in Islamabad. So we will have to figure out with the local teams what will work. And our work right now in the sociology of type 2 diabetes, and Salome Gregorczyk-Martin kicking off the culinary medicine work would be critical and essential to be able to adapt the protocol to success, right? So that is very important. So think about it. We randomize clusters, but we transform communities. And those who are in the standard of care will be given the first right to refuse to adopt the 520-35 model beyond the scope in the capacity building phase of ICEHALL and the 520-35 vision, right? Ladies and gentlemen, the CHO. Know it, love it, and be able to talk to it to someone who is even disinterested as an elevator pitch. The community health officer is an invention of the 520-35 model and vision. This does not exist anywhere, this demarcation. And we have spent years thinking about it and setting the community health officer. The community health officer, for those who are new to the mission, is an advanced level nurse practitioner that will have three pillars of activity. Pillar number 1, clinical excellence. Pillar number 2, community organization. Pillar number 3, as the guardian of learning health system and as the implementer of learning health system in communities. We have talked about it extensively, but the CHO is going to be that invention that will change the world. And in the way that we have thought about it in a rigorous, dedicated, and in a sustained manner, I think with Ashima's working on the final details of the research CHO curriculum, we will be able to articulate that much better. So around the CHO, though, we have the content experts, all of us here, some of us here, and others. And then you have the officials and institutions that the CHO will intervene, and the behind the CHO, of course, is the community health doctor, and then the community. that trust triangle must be there for us to be successful. And we have spent years in communities like Espérance Trébuchet, like the CCDC people at Visakhapatnam, and Razi Hospital in the outskirts of Islamabad, and Saraswati Nagar's Prajwal's previous work. So we have already established roots in the communities where we're going, but getting buy-in from the community makes that trust triangle very important, right? So the community block is the working model. It's, again, as we have talked about extensively, it's about 1,000 inhabitants in family units who have an elected or selected community health committee. The CHO is the sort of center of it all, and the clinical and scientific support by all the infrastructure that we're going to build through the handheld devices, through our AI measures. Quentin Adam, our chief digital officer, has been worked for years on this, and together with us, we are extremely pleased to have Professor James Hillis from Harvard, who's going to be leading the AI implementation component of the protocol. So that is going to be important. I talked to him on Friday. He is obviously excited, and we're going to be working together on that. The governmental and institutional interface is as important. If it doesn't happen, then we don't move forward, right? And here I must salute the amazing work that Professor Varma, Professor Shah, and others at the other sites have done to have that interface, to be able to us to be a known factor, not someone who's just coming out of Boston and telling people what to do. So that's also very important. And that's part of the community block. How do we, from the get-go, start inserting into the existing infrastructure so we don't seem as threats to the people who are already there in the ecosystem? How do we bring them along to provide value to their services? And that kind of working things out in the local context, empowering communities and institutional government institutions is going to be key for us to succeed in ICEHALL in the operational and the capacity building phase, right? So in essence, if the community is only where data are collected, like most trials do, we will fail, and we will fail royally, and we will not fail. But if the community is empowered to become an active advocate of its own health and capacity build for their larger communities and their countries, then ICEHALL can become self-sustaining, and the 520-35 model and vision will become a reality. That's what that's the hard sell that we have to make happen, and we will make that happen. So the intervention architecture, I want to belabor that a little bit more because this is important. The CHO-enabled community block is at the very core of what ICEHALL is going to be driving, right? So the CHO and the community, the content experts, and the officials. That's the trust triangle. So CHO in the middle. They will be implementing, the architecture will be the clinical algorithms. That is going to be a work that we started in 2017-18, but I will want to have a group working on it, on the clinical algorithms, to get back to some people. And I'm looking at some of the young leaders in health already. I will be talking to them to help design the clinical algorithms. So these clinical algorithms are low and medium complexity clinical issues like foot care, like HB1C monitoring. What is the latest that we need to do? And implementing it in a very easy flow that the CHO in the field can take a look on the handheld device and be able to implement the action in constant contact with the community health doctor, right? So that's important. The CHO curriculum and certification is going to be a huge work. Our chief curriculum officer in the past, Bill Burke, has worked tirelessly with Dr. Valma to have the elements of the CHO curriculum and certification. In Mauritius, we are in an advanced stage in how to certify that. With Dr. Gupta on board now, I think we're going to be able to drive that to realization, and it will happen in the next 6 months. Again, to looking to Dr. Gupta, culinary medicine we have been working on this without having a name of what this is about. But in essence, culinary medicine, we look to food as medicine. And so with Dr. Gupta's help, we will implement that in a more rigorous, articulated manner within our diet, healthy lifestyle and diet intervention scheme within the ICEHALL framework. Community mental health. Dr. Sufi has been working on this for years now, from the Dixon Chibata Zimbabwe model of having training lay people to do cognitive behavioral therapy. So as a background, most healthcare are low and medium complexity. Most healthcare outcomes are fundamentally affected by stresses and strains that the patient is undergoing, that the community member is undergoing within the context of their life, right? So having a constant community mental health without calling it so, that can provide low-level cognitive behavioral therapy help to drive people to better behaviors, adaptive behaviors would be important. And that community mental health within the framework of the CHO is going to be an important thing to do. Digital health infrastructure. I'm going to utter the word AI, but we're not going to use AI as the whiz-bang thing. It's how do we build digital health infrastructure empowered by artificial intelligence and machine learning for LMICs, not for Boston, not for Louisville, Kentucky, but for Islamabad, for Saraswati Nagar, for Espérance Trébuchet, and for Visakhapatnam, at the level of infrastructure that they have, and how do you adopt that? So that is also going to be the intervention structure, and understanding that in the next 6 months is going to be important, together with James Hillis and Quentin and others that have been working on it. The learning health system is also very important for sustainable changes. And that goes back to this seed scale development theory. It goes back to the learning health systems and empowering communities to take their health in the hands rather than in the economic model be consumers of health. So in the social development seed scale theory, we look at healthcare as a social institution, not primarily as an economic institution. And the learning health system of empowering people to get right health measures is going to be very, very important. And that's the third pillar of the community health officer, right? So in essence, then ICEHALL is an integrated intervention. The community health officer is the organizing and implementing instrument of that vision. What we will measure, we have talked about that at length. We'll measure, and clinically in the trial, we'll measure hemoglobin A1C, blood pressure, so on and so forth. We will measure behavioral outcomes as the diet quality change, as the food access change, has the adherence, has family engagement been there. Health system and economics is a huge component, because without providing value to policymakers and politicians, it's going to be a no-go. So healthcare utilization, how much does the CHO cost in Visakhapatnam? How much does usual healthcare cost is for the family? How much does it cost for the government? And how would it change? Those are going to be important inbuilt outcome measures that we'll be looking at. Implementation and equity is also important, looking at the capacity building. How can we make things feasible for Mauritius, in Mauritius, for Mauritians, in Islamabad outskirt, for people in the region, for Pakistanis, and so on and so forth. So not so much academic, but practical. How do we make things work in a MacGyver sort of way? There are no single biomarker that can carry the full claim of ICEHALL. As you guys can see, we're deeply thought about in several different layers and levels, and understanding all of that measures is going to be very, very important for all of you guys in the core team here. I wish James were here, but James has said he was going to try to make it to the meeting. But he and I have been talking about the digital health. He is, Dr. Hillis is the director of the AI implementation at the Department of Neurology at Mass General Brigham and Harvard Medical School. He's a colleague and friend of mine. And we have been having thoughtful discussions in how do we adapt AI implementation, data sovereignty, because when you think of digital health, it encompasses a whole bunch of things. And those bunch of things include the community and how the CHO would interface. How do we capture data in different resource pool environments? How do we de-identify the data for the data coordinating center in Mauritius? How do we use dashboards to monitor live how each site, as I do in my trials, I want to be able to wake up in the morning and look at a dashboard and know exactly what are the pain points in each of the sites, what needs to be done. So how do we implement that? There are ways of doing it that we can use in a cunning way, and a way that will help us in resource limiting environments. AI is not going to be the answer to everything. We're going to see whether implementing it is going to be feasible. How do we have protection so that hallucinations don't happen? How do we validate? How do we have human intervention at every step so that care is provided in the most rigorous way? What are the guardrails? Those guardrails, as you guys have read and know, AI in medicine is huge, and we're going to be implementing and living that, testing it in ICEHALL so that when it's capacity built, we have a chance for AI being for the greater good in health. We will use digital health aggressively, but we will govern it conservatively. We want to give ample reassurance to the public, to policymakers, to politicians, and to us that we're using this new powerful tool in a way that is going to be helpful and not hurtful, both ethically, economically, and otherwise to the communities we are dedicated to serve. IRB implementation and readiness is going to be important. The tier ones are there are a lot of things that are missing in the protocol right now. We need to confirm the legal infrastructure. We need to clarify the implementation in Mauritius with Professor Chanson, and because that will be the first site, we'll have to clarify that in the months to come. We'll have to define the MGH human subjects roles and finalize the consent data flow. Tier 2, there are other safety escalation pathways. Those are typical things that you run in a clinical trial. We will set those up. And then implementation details. So in the next 6 months, we need to have rigorous understanding of how it's going to be implemented within Espérance Trébuchet, how we're going to move at Vallée des Prêtres, in Rodrigue, in l'Escalier, wherever that may be, how things are going to move in Mauritius, so that when we get the funding, we're not going to be like, oh, now let's start thinking about it. No, it's not going to be thinking about it. It's going to be, let's do it, and let's do it now, yesterday. That's going to be the urgency and the sense we're going to do to be able to aspire to 5-20-35, which is decreasing uncontrolled diabetes to 5% by the year 2035. And we are going to be there to meet the moment. The protocol is doing its job at this time of version 8, but I will rely on you. I have that version 8 is the summum bonum of all that has been done with all of us over the last 17 years. Now it's all of us to work as a community to make it operational and rigorous in a way that's going to be field defining. These are what we need from the research groups in the days and weeks to come, and I'll work very closely with Prajwal and Dr. Valma and Salman to get those agreements done, and let's get to work. Right, there's a whole bunch of these coming up. So from comments to commitments. Version 9 should not be my private rewrite, folks. It should be the research group's conversion of version 8 into submission-ready, fundable, operational protocol. Okay, that is very, very important. We are doing very, very well where we are. Now we need everybody's help to make things happen. So we have discussions that I'm going to stop presenting here, and I would invite people for their comments, questions.